Okay, now, any question before we start the class? Okay, if we don't have any question, then we start with chapter 10, that is alteration in immune function. So we are going to be talking about the immune system. Immune systems is a defense body against invasion or infection by antigens. So anything that try to get in our body, the first defense mechanism is the immune system. Type of alteration, we have an excessive immune response and deficiency immune response. Both sometimes produce damage to our body. Okay. Increasing immune system activity type, we have autoimmunity and hypersensitivity. Autoimmunity is an immune system attack on tissue. That's why we have some type of diseases that are autoimmune disease, because it's a problem in the autoimmune system. And hypersensitivity is described the mechanism of injury may or may not involve autoimmunity. Autoimmunity, an individual's immune system recognizes its own cells as a foreign. One class example for this is the MS, multiple sclerosis. Multiple sclerosis is that sometimes your immune systems, they recognize their own cells as a foreign body, and then they build an immune response. Right here we have possible theory, antigenic mimic theory, cell-foreign antigen made same material, so a small alteration in cell tissue lead to attack, and release and sequestration of antigen theory. That's the other theory. Another possible theory is the T-cell theory, thymus gland defect. Remember that the thymus is a gland that we have right below the thyroid glands, and is the maturation of the T cell in our body. But the glands disappear around 13 years old. Also, we have the B cell theory. B cell lost their responsiveness to precursor T cell signal over bacterial B cell, mast cell theory. And the mast cell, remember, that have the granules, and the granules release the cytokines. Genetic factor, different cytokines can be associated with autoimmunity. MHC genes, HLL, some associated with certain autoimmune disorder, appear to increase risk of autoimmune disorder. Gender and issue, female at higher risk. Environmental trigger, of course, when we are exposed to environmental, there is a lot of factors that contribute to produce immune response in our body, okay? Like bacteria, viral, fungal, parasite. Then we have the treatment, individualized immunosuppressive therapy. That treatment is not only when you have immune system problem with the immune system, also when you have like any transplant in your body. Remember that when you have a transplant in your body recognizes that graft as a foreign. So we have to put the immune system down that we don't have any reactions. And we have question number 1. Which genetic aspect is associated with development of autoimmune diseases? And out of that list, the answer is D, exactly. This is related to autoimmune diseases. Right here, okay? Now we have hypersensitivity. Hypersensitivity, we are gonna cover the most important, the details that you have to know, okay? Because hypersensitivity is a really complicated topic, okay? Let's come to the hypersensitivity. We have 4 types of hypersensitivity, 1, 2, 3, and 4. Right here, we made the first difference, okay? 1, 2, 3 are mediated by antibody produced by the B lymphocyte, and type 4 is the only one that is cell mediated. Cell mediated, especially the T cell. Okay? That's one of the main difference. Okay? Now we have hypersensitivity 1. What is extremely important hypersensitivity 1? This immunoglobulin E. Okay? Immunoglobulin E is a release of immunoglobulin, formation of immunoglobulin E, and is the one that produces the reaction. Pathogenesis, also known as immediate hypersensitivity, because it's really fast, and the reaction is 15 to 30 minutes after the exposure. Immunoglobulin E is the principal mediator antibody. Mast cell and basophil are principal effectors. Okay? Pathogenesis, we keep going with with hypersensitivity 1. You see again immunoglobulin E. Remember immunoglobulin E, hypersensitivity type 1. Okay, that's the most important. Fc receptor, this is one part of the immunoglobulin. Okay, immunoglobulin have an structure, and one part of the structure is the Fc. Pathogenesis, increased intracellular calcium result in immediate massive local mast cell degranulation and proliferative mediator. Okay, the mast cell is the one that releases the histamine, and histamine produces the reaction. You see right there, that's one of the main substances that are released. It's extremely potent vasoconstriction, vasodilator, okay, and produce inflammation. Most important mediator cause increased vascular permeability, vasodilation, urticaria, and so on. Okay, have different receptor H1 to H4. That's why one of the treatment is antihistamine. The antihistamine is medication that block those receptors, especially H1 and H2. Clinical manifestation: mild heat, seasonal allergy, rhinitis, eczema. More problematic is throat constriction, localized edema, and anaphylaxis. Anaphylaxis is the worst reaction and is an emergency condition. And that's why people that suffer for anaphylactic reaction, they always carry an EpiPen, because that's the treatment. Epinephrine. Treatment: antihistamine, beta-adrenergic, corticosteroids, and anticholinergic. Okay? This epinephrine. Also, we have immunoglobulin E theory, inhibit binding of immunoglobulin E, and epinephrine right here. Okay? Prevention: infancy and pregnancy. Several methods to decrease the chain of the one hypersensitivity reaction. Pharmacological desensitizations. This is especially, for example, if you have a pregnant woman that need, like, for example, penicillin, and sometimes we have to do desensitization, okay? Give the penicillin to that person. Okay, now we have hypersensitivity type 2, also known as a tissue-specific cytotoxic or cytolytic hypersensitivity. Listen, this is extremely important. Okay? Remember, immunoglobulin E, type 1. This is type 2. Okay? That's extremely important. And we have the transfusion reaction, is a type of hypersensitivity type 2. Okay, recipient's antibody attached to the donor's red blood cell antigens. Hemolytic disease of the newborn due to Rh. Okay, the mother has to be Rh negative, and the baby has to be Rh positive, and is always in the second pregnancy. Okay, because in the first pregnancy, the mother developed the antibody, and then in the second pregnancy, the mother transferred those antibody to the baby, and then produce the lysis of the red blood cell, that is destruction of the red blood cell. Hemolytic disease of the newborn, mother received the mother immunoglobulin G Rh positive antibody across the placenta. Remember that Rh is mediated by immunoglobulin G. Immunoglobulin G is a really small molecule that have the ability to cross the placenta, okay? And that's why it go to the baby. This is the treatment, is a Rogan. You give the Rogan in the first pregnancy. After they finish the first pregnancy, you give the Rogan. Rogan give it, I think, week like in week 30, around week 30. And after the woman give birth, also we give another dose. This is an example of type 2 hypersensitivity. We have a disease that is myasthenia gravis. That is a problem in the acetylcholine receptor in the neuromuscular junction. Graves' disease is a type of hyperthyroidism. Okay? Graves' disease is a hyperthyroidism. It's also type 2 hypersensitivity. And hyperacute graft rejection is a type 2 hypersensitivity. Now we have type E. Okay, remember, the first one is immunoglobulin E. The second one in the Rh reaction, immunoglobulin G, and it's a cytolytic. Okay, this one is an immune complex reaction. That's extremely important. Deposit of antigen antibody complex in the tissue result in activation of complements, cell sustaining inflammation. Okay, I'm giving you just the most important part that you have to know, okay? Possible etiology, recent history of infections, and extrinsic environmental antigen, and autoimmune process can develop in which antibody attack cell antigen. Mechanism of injury, activation of complements. Have different type of complement. When you activate the complements, they produce inflammation reaction, and then you have the hypersensitivity reaction. Tissue injury is caused by inflammatory reactions of the antibody antigen complex. Okay, this is extremely important. Okay, because it's how the reaction takes place. Okay. Pathogenesis, we have involved antigen formation antibody. From here, what is extremely important is every time that you see that C right there, that means complements, okay? So you have problem with complements, then you have problem with hypersensitivity type T, and also MAC, that is membrane attack complex. Okay? Phagocytic cell lysis and destroy tissue from cytokines and inflammatory response, cause tissue destruction, scary for the reaction of the immune system. Tissue deposition, smaller immune complexes, circulatory for longer period may increase immune response. Very large complexes can be phagocytized more easily, and can also become stuck in the kidney and produce problem in the kidney, and that's one of the diseases because of the position of that complement in the kidney. For example, post-streptococcal glomerulonephritis is a type of type 3 hypersensitivity reaction because post-streptococcal glomerulonephritis is accumulation of complement T in the kidney. Tissue deposition, intermediate site complexes tend to deposit in tissue. Let me see. You see right here, that's extremely important, okay? An example of type 3 hypersensitivity, okay? That is post-streptococcal glomerulonephritis. Immune complex glomerulonephritis, another name is post-streptococcal glomerulonephritis, okay? And it's due to deposition of complement T in the glomerular. Systemic lupus erythematosus, that's another example of type 3 hypersensitivity reaction, okay? It's more common in women because lupus is more common in women. Delay, now we have type 4. Remember, at the beginning, we established the difference between 1, 2, 3 with 4, okay? Type 4 is a cellular mediated, it's a T cell mediated, okay? So this one is a delay, so it's gonna take more time to produce the reaction, okay? You see principal effector cell, lymphocyte, and macrophage sensitize T cell reactions, okay? That's extremely important. Now we have cutaneous basophil hypersensitivity, most rapid type, skin swelling, skin graft reaction, and rejections, I mean. Contact hypersensitivity, most familiar type, epidermal phenomenon. In that we have the contact dermatitis. The contact dermatitis is a type 4. Okay? When you receive the PPD, that is a test to see you have tuberculosis, that's a type 4 hypersensitivity reaction also. Okay? Tuberculin type hypersensitivity, that's the PPD, okay? Purified protein derivatives, that one means PPD. That's why you put the purified protein derivative in the skin and then you measure 48 hours. So 2 days later, from 2 to 3 days later, you measure the endurance, okay? You don't measure the redness, okay? They produce redness, but you don't measure the redness in the PPD. You measure the endurance, what part is hard. Glomerulomatous hypersensitivities, primary defense against intracellular infections, present a chronic type 4 hypersensitivity reactions, protective defense reaction that eventually cause tissue destructions, and so on. And we have question number 2. Which of the following disorder display this characteristic? Failure to remove antigen-antibody complex is not tissue specific, include antibody occur over several hours or day, also called immune complex reaction. You see right here we measure the key point that you have to know to answer this question, okay? So this question, the answer is this one, okay? Right here. It's a type 3. Type 3 is immune complex reaction. It's antigen-antibody, okay? Now we have deficiency in immune response result from functional decrease. We have two types. We have primary and secondary. Primary is congenital. That means that you are born with the problem, exposed to multiple deficiencies. Secondary is non-immune system disorder, treatment that secondarily affect immune function. Can affect lymphocyte, antibody, phagocyte, and complement proteins. Primary immunodeficiency disorder may be from congenital genetics or acquired defect that directly affect immune cell function. Rare and often sex-linked. That's how you transmit the disease. First clinical indicators, sign and symptom of infection. Basically, that's the main sign and symptom, because if your immune system is low, you are at risk to develop any type of infection. Suspect with severe, recurring, unusual, or unmanageable infections. Most common moderate immune impairment that may not be diagnosed. Those conditions are extremely weird, okay? Maybe when you get to the hospital, when you become a nurse, and you are practicing for a couple of years, maybe you see one case, but are extremely weird, okay? It has SCID, this everybody knows as SCID, that is severe combined immunodeficiency disorder, impaired T and B, okay, both, okay? The way that we learn those diseases is according to the cell that is affected, okay? So SCID affect both T and B. Okay, characterized by severe immune system dysfunction. Okay, most of the time they call the bubble babies, okay? That's ESKI. Also, we have, and one of the main characteristic is you develop the disease in the first month of life, okay? Right after the baby is birth, they start developing all the problems. And it's extremely similar to newborn baby with HIV, okay, because both conditions are very similar, because both affect HIV, also affect the lymphocyte. So those patients are at increased risk for opportunistic infection, okay, like fungal infection and TB. Sorry. Now we have Weill-Albrecht syndrome. Is an X-linked immunodeficiency disorder that affects T and B cell. Okay, Weill-Albrecht. How do you remember? You say water. Okay, water. W and A is for Weill-Albrecht. E is for thrombocytopenia. Those patients have the platelet low. E stands for eczema. Those patients most of the time have eczema. And the R stands for recurring infection. DiGeorge syndrome is a genetic disease that is a deletion right there in the 22q11 gene, associated with total or partial loss of the thymus. Most of the time, those patients doesn't have thymus. Okay, that's one of the main characteristics. No thymus. Okay, in this case, right here, those patients have problem in the lymph node. Okay, most of the time doesn't have lymph node. This one doesn't have thymus. Okay, DiGeorge. Also, DiGeorge have problem with the calcium. They have problem in the face. They have some special characteristic deformity of the face. Those are one of the main characteristics of that disease. Chronic mucocutaneous candidiasis. Those are patients that are at risk to get infected with this fungi, that is Candida albicans. Okay? They have chronic candidiasis. Okay, they get candidiasis, you treat, and later, 2 months later, again candidiasis, and that's why the name. Now we have immunoglobulin A deficiency. That's another type of immune diseases. One of the main characteristics of immunoglobulin deficiency is that those patients can't receive any blood transfusion. Okay, if they receive a blood transfusion, they develop the reaction, okay? Because you have to remove the immunoglobulin A from the blood to be able to give the blood to those patients, okay? Bruton's agammaglobulinemia, Most of the time it's an X-linked, but also they sometimes have autosomal recessive transmission. Okay, X-linked is more easier. Why? Because it's in male. Okay, always is gonna be a male, and it's B cell deficiency. Okay, and those patients start developing all the infection after 6 months. Okay, because in the first 6 months they have the immunity from the mom. Okay, from the immunoglobulin that they get from the mom. Now we have transient hypogammaglobulinemia. Okay, it's a self-limiting conditions. Infant is slow to acquire, and also we have this one that is also another one that is really well known, that is common variable immunodeficiency. Common variable immunodeficiency is similar to this one, okay, gluten. The only difference is that common variable immunodeficiency, you develop that disease in the 20s, okay? In the early 20s, the people develop that disease. And it's characterized by low, that you have all the immunoglobulins are low, okay? And we have question number 3. DiGeorge syndrome is a deficiency of. What is the answer? And the answer, of course, DiGeorge is T cell. Okay, problem with the T cell. That's DiGeorge. Secondary immunodeficiency disorder. Fact, we have excesses of defective neuroendocrine response, excessive increased corticosteroid, increased susceptibility to infection, defective low corticosteroid, increased susceptibility to autoimmunity. We have different factors for secondary immunodeficiency disorder like poor nutrition, stress, drugs, surgery. In stress, we have alcohol, and alcohol leads to poor nutrition. Okay. Any question from this chapter? Listen, I know that information from this chapter is really hard, it's extremely complicated, but always remember that you have to focus in the keywords, okay? In the hypersensitivity, I give you the keywords. Those are the keywords that you have to know, okay? With those keywords, you're gonna be able to answer any question. So if you don't have any question, then go to the next chapter. Professor, are you going to send the PowerPoint? All the PowerPoints are in your Blackboard, okay? The first week, the first video that I post in the first week, I explained that when you go to the Blackboard, in the instruction block right there, when you click, it's gonna open a lot of like folders, and the folders say with 1, with 2, with 3, and with 4. In those folders, when you open the folder, you have all the PowerPoint plus the review of that week. Okay. In week number 2, there is no review because now I'm making the review. Okay. But from week 3 all the way to the end, you have all the reviews. Okay. You're welcome. Also, what else? Yes, it's right there. But now, when I finish this class, I'm gonna send it through the reminding app. Because always at the beginning of the week, always in reminding app, I send all the PowerPoint. I don't know if I did it this time. I'm gonna do it right now. Right now, no, when I finish the class. Okay, now we have malignant disorders of white blood cell. Okay. In this chapter, we are going to be talking about leukemias. Okay, right here we have leukemias, lymphoma, and plasma cell melanoma, that is multiple myeloma, and so on. Okay. Now, lymphomas tend to localize in lymph tissue, is often disseminated to other site of diagnosis. Okay, one special characteristic in lymphomas is that the lymph node, you have lymphadenopathy. Lymphadenopathy is inflammation of the lymph node, okay? That's the medical terminology to describe inflammation of the lymph node. The lymphadenopathy in lymphomas is non-tender, no pain. Okay, that's one of the main characteristics. Because if you have lymphadenopathy that is tender or painful, most of the time, basically always is infectious disease. Okay, like viral, bacteria, fungal. Typical sign and symptom: malaise, weakness, unexplained fever, night sweats. Those are called B symptoms. Okay, recurrent infection, large, non-tender lymph node. That's a special. Okay, and so on. Characteristic. Categories based on the cell type of the neoplasia rather than its location. Of course, leukemia is according to the cell that is the lineage of cell that is affected. Okay, and right here you have myeloid lineage is the red blood cell, platelet, monocyte, and granulocyte, and lymphoid lineage is the B and T cell natural killer. And we have question number 1. An example of neoplasm from the myeloid lineage include alteration in. What is the answer? Exactly, granulocytes. Okay, because B, T, and natural killer, you have it right here, is the lymphoid. Okay, B, T, and natural killer, lymphoid. Classification: hematologic neoplasm. We have myeloid neoplasm, that is myeloproliferative, myelodysplastic proliferative disorder, and so on. Okay, we're gonna see all of them right now. We have non-Hodgkin lymphoma. It's a lymphoma of the B, T, and natural killer. Exact cause of hematologic neoplasia is unknown. Base mechanism involves cell mutation and disruption of growth control and differentiation pathway. Possible cause: virus. There are different types of virus that produce lymphomas, like Epstein-Barr virus that produce Burkitt lymphoma. Burkitt lymphoma is a type of non-Hodgkin lymphoma. Okay. Radiation exposure, chemical exposure, reduction of alteration, some genetic disorders. Most common clinical manifestation: leukopenia. Leukopenia means that all the white blood cells are low. Okay, that means white blood cell low. Okay, lymphadenopathy, joint swelling, weight loss, and anorexia, hepatomegaly, splenomegaly. Most common clinical manifestation of hematologic neoplasm is anemia. Anemia produces pallor, fatigue, malaise, shortness of breath, and decreased activity tolerance. Okay, and some at the beginning of anemia, they can produce tachycardia. Now we have thrombocytopenia. That means that the platelet are low. When you have platelet low, you are at risk to bleeding, and bleeding can produce petechia, easy bruising, bleeding of the gums, ocular hematuria, retinal hemorrhage. Neutropenia, absolute neutrophil count less than 500. Evaluation of peripheral blood sample, key aspect of diagnosis, and definite diagnosis is usually made after bone marrow aspiration, that is basically bone marrow biopsy, okay, and lymph node biopsy. Principal treatment, combination chemotherapy to remove malignant cell, that's the primary. A stem cell most of the time is curative, okay, in some case, okay. Also, you remember the immune deficiency diseases, some stem cell is also curative for those diseases, okay. Chemotherapy induces long-term remissions, complete remission, return to normal hematopoiesis. With normal hematopoiesis is normal production of the red blood cell, okay? Normal red cell, neutrophil, and platelet count. Chemotherapy, complete remissions, not a cure. You have to be very careful because the disease sometimes have the ability to get back, okay, and then you again have the disease. Usual treatment protocol include many chemotherapy cycles. Chemotherapy treatment phases, remission inductions, post-remission or consolidation, and remission maintenance, okay? Those are the different phases of the treatment, okay? Chemotherapy, intermittent chemotherapy may be continued for 2 to 3 years after initial induction of remission. Is CNS add as a secondary for neoplasia cell, chemotherapy agent can be administered. Sometimes there is a type of leukemia that have exposing to CNS metastasis, and prophylactically you give chemotherapy to the CNS in those patients. Okay. Maintains adequate nutrition status. That's extremely important when the patient is in chemotherapy. Okay, because that avoid anorexia, weight loss, avoid anemia. Infection, we have prevention, early detentions. Sometimes you give prophylactic antibiotic to the patient. Bone marrow transplants used to manage certain leukemia. Bone marrow fail as a result of intense chemotherapy. Of course, when you are giving chemotherapy, remember that that medication not only kill the bad cell, but also kill the normal cell, okay? We have autologous transplantation. Those are the type of transplantation. Is an stem cell from patient's own cells. Allogeneic transplantation is a stem cell from closely matched relative, and graft versus leukemia. That's another type of transplants. Anemia, common complication of leukemia and chemotherapy. Of course, remember one of the main side effects of chemotherapy is bone marrow suppression, and if you suppress the bone marrow, you don't produce the red blood cell, and then you develop the anemia. Okay? Also, the disease by itself, because chronic diseases produce anemia, okay? Because there is a type of anemia that is anemia of chronic diseases. Thrombocytopenia, platelet deficiency with possible hemorrhage, fresh frozen plasma, pooled platelet, protect from trauma. Those are the treatment, okay? Pain, common complication of both disease process and diagnosis treatment protocol. Remember that most of the time the neoplasias produce a lot of pain, and then you have to control that pain because you have to give quality of life to those patients. Okay. In management, we have narcotic and non-narcotic drug distraction, biofeedback. Most of the time, you have to put the patient in opioids, okay, especially morphine. Damage to epithelial cells from radiation and chemotherapy, loss of skin, Membranous hair is one of the most common, but always remember that the first sign and symptoms when you put a patient in chemotherapy is diarrhea. Okay? Myeloid neoplasm result from transformation proliferation of precursor stem cell in the bone marrow. That means alteration in the bone marrow. A normal stem cell is multipotent. Multipotent means that have the ability to become in a lot of type of cell. Okay. Common myeloproliferative disorder, we have CML, that is chronic myelocytic leukemia, polycythemia vera, and essential thrombocytopenia. Polycythemia vera means a lot of red blood cells, and sometimes is also uh, increase the platelet and increase the white blood cell. Essential thrombocytopenia means that the platelet are low and is the only one that is low. Okay? Usually discovered on CBC analysis, common feature involve of multipotent hematopoietic progenitor cell, marrow hypercellularity, overproduction, chromosomal abnormality, myelodysplastic syndrome, and AML. And AML means acute myelocytic leukemia. Neoplastic cell prognosis is poor and intensive treatment necessary to extend life. Now we have the chronic myelocytic leukemia. Pathogenesis and clinical manifestation represent approximately 15% of the case of the leukemia. Average onset, this is extremely important always that you have to know the age, okay, because that gives you an idea the type of neoplasia, okay, only when you see the age, okay. Occur only occasionally in childhood and adolescence. Pathogenesis, we have characterized by malignant granulocyte. This is an extremely important part of this Philadelphia chromosome. Philadelphia chromosome means translocation of this from 9 to 22. Okay, that's the Philadelphia chromosome. Another characteristic is this. Okay, the Philadelphia chromosome is a BCR-ABL gene. Okay, that's why the treatment for that condition is a medication that targets this. Okay? Prognosis of clinical CML cell have greater degree of segmentation than AML cell. Usually clinical presentation, high granulocyte counts, and splenomegaly. That's really common in that disease. Pathogenesis and clinical manifestation. Symptoms, of course, always you have the B symptoms, okay? Fatigue, weight loss, sweat, bleeding, abnormality disorder. But most of the time when you have a chronic condition, okay, chronic conditions, you don't have any symptom, okay? In chronic condition, the problem is when you do the CBC, the white blood cells are gonna be extremely high, okay? Those symptoms are more common in acute conditions, okay? Prognosis and treatment. CML does not respond well to chemotherapy. Untreated, if you don't treat the patient, survival rate is around 2 years. Last stage CML, basically AML, have a very poor prognosis, only 3 to 4 months. Prognosis and treatments. This is the medication that is used, the most common one, okay, to treat the condition, imatinib, okay. Also, we could do bone marrow transplant. That means bone marrow transplant. Now we have acute myelocytic leukemia. In acute myelocytic leukemia, the age is around this. Okay, remember the previous one 50 to 60, and this one, I mean 40 to 50, and this one is around 64. Okay? Bone marrow aspiration must have 20% blast. That's extremely important, okay? Because that's the characteristic of the acute lymphocytic leukemia. Prognosis and clinical manifestations. We have susceptible identified by stage at which development stop. Most common type of AML, acute granulocytic leukemia, so on. That's not extremely important. Okay, pathogenesis and clinical manifestations. Always lost. Remember the P53 and the RV gene those are the check mark in the cell cycle. If you lost those genes, the outcome is gonna be worse. Now we have a presentation very similar to acute lymphocytic leukemia, bone pain, anemia, thrombocytopenia. With anemia, you have fatigue, anorexia, uh, low tolerance to exercise. Okay. We have abrupt onset of symptom, prognosis worse for AML than ALL. And this is another type that is acute polymyalocytic leukemia. Is the most curable of the acute myelocytic leukemia. Prognosis and treatments, treatment protocols incorporating cytogenic profile of the leukemia cell. We have two phases. We have remission inductions and consolidation. That's the only two phases in this treatment. Even when complete remission is if achieved, patient almost always have recurrence. That's why you have to always follow up those patients. Okay, always. Now we have lymphoneoplasms include malignant transformation of B, T, and natural killer. We have leukemia when present in blood marrow, lymphoma when localized in lympho tissue, lymphoneoplasm localized sequence of the disease stage. WHO is a World Health Organization's classification use cell type, not stages to classify. Now we have the subcategories of B cell and T cell natural killer group. Precursor cell neoplasms characterized by cells that have arrest development in early blood stage. Mature cell neoplasm more differentiated than precursor cell. Right here we have chronic lymphocytic leukemia. In chronic lymphocytic leukemia, 30% of the case leukemia in the United States, 90% are malignant B cell precursor. Remember that we have B cell and T cell in the chronic lymphocytic. Symptomatic chronic lymphocytic leukemia, fatigue, weight loss, anorexia, increases susceptibility to infections. All those patients are always increases susceptibility to infection. Why? Because you don't have T cell and B cell. Basically, that's your mechanism of defense to any foreign body. Okay. Malignant lymphocyte invade lymphoid tissue and bone marrow, destruction functions, large painless lymph node. Remember, that's one of the main characteristics. And large spleen. That's large spleen means splenomegaly. Prognosis and clinical manifestation: bone marrow infiltrations, production of red blood cell, platelets, preponderance of lymphoid cell, CLL cells characterized by defective apoptosis and longer lifespan. That's pretty common in any type of neoplasia. Prognosis and treatment, certain genetic mutation present better or worse prognosis. Chemotherapy is one of the main treatment, and also stem cell transplant. Okay? In leukemias, stem cell transplant is really widely used, okay? Because the outcome is really good. Malignance, now we have acute lymphocytic leukemia. Acute lymphocytic leukemia, malignant disorder of lymphoid cell lineage. 80% results in malignant transformation of the B cell, 20% the T cell. Now we have the pathogenesis. Listen, right here we have an extremely important keyword, okay? And it's the age, okay? Acute lymphocytic leukemia is really common in childhood, okay? Symptoms of acute is abrupt, that is more severe. It's bone pain, bruising, fever, infections. Children may refuse to walk, loss of appetite, fatigue, abdominal pain, and so on. 3% may present with CNS signs. Why? Because ALL can produce CNS metastasis. Okay, that's why sometimes as a prophylactic you give radiation therapy to the brain. Prognosis and treatment, 85% 5-year survival rate in children, 50% in adulthood, always basically in all type of neoplasia. The outcome is better in childhood than in adulthood, okay? Prognosis and treatment, post-remission chemotherapy with or without stem cell transplants indicated for most patients. Adults, of course, you have to give more therapy because the outcome is worse in adulthood. We have question number 2 right here. Which of the following leukemias presentation is primarily found in children? You see, you have to know always the age, okay? And what is the answer? The answer is this, okay? Right here. B, remember, ALL is the normal onset is between 5 to 7 years old, okay? Hair cell leukemia is like a type of leukemia that one of the main characteristics is the cytologic characteristic, okay, under the microscope. You're gonna see hair-like projections, but you only see this in the microscope, okay? Prognosis and clinical manifestation, hair cell in peripheral blood, reduced number of granulocytes, and splenomegaly is a common characteristic. Treatment begins when the patient becomes symptomatic. That's special, okay? If the patient doesn't have any symptoms, you don't do anything, okay? Once the patient is symptomatic, that start develop symptoms, then you treat the patient. One of the common symptoms is splenomegaly, recurrent infection, bleeding, and anemia. Plasma cell myeloma, that is multiple myeloma. This is also known as multiple myeloma, is malignant of the B lymphocyte plasma cell. Okay, B lymphocytes. This is special for this, and the median age is this. That disease happen in adulthood. Okay, in elderly patient, more common in men than women. Malignant plasma cell involve bone and form multiple tumor sites, may also target other tissue including lymph node, liver, spleen, and the kidney, because that's one of the signs and symptoms, kidney problem. They have something that is called, let me see if they describe right here. Okay, they don't describe, but they have some what we call CRAB symptoms. CRAB symptoms is calcium problems, anemia, renal problems, and I don't remember the other one, but those are the main characteristics. You can see right here that they produce the B Jones protein, and that B Jones proteins is the one that affect the kidney. Okay, accumulation of that protein in the kidney produce blood in the urine. Okay. Also, they have problem in the bone. Why? Because they have hypercalcemia, because they produce, I think, interleukin-1 and another cell that cell stimulate the PTH, and the PTH start getting calcium from the bones, and those patients have lytic lesions in the bones. Okay, when you have an X-ray, you are gonna see like black points in the bones. Okay. Prognosis and clinical manifestation. Prognosis based on monoclonal antibody peak, presence of B Jones protein, hypercalcemia, and evidence of bone lesion. Okay. Bone marrow biopsy confirmed the diagnosis. Plasma cell occurred 80% to 95%. And now we have prognosis and clinical manifestations. It's slow, insidious. This is another disease. Okay, that's not the same disease. They put right here multiple myeloma continuation, so forget about this. Okay, because Angus is monoclonal gammopathy of undetermined significance. Okay, that's another disease. Okay, that's malignant stage appearing in some individuals with excessive production of monoclonal antibody, but no bone lesion or B Jones proteins. Okay, that's one of the main characteristics. Angus doesn't have the CRAB symptom. Okay, they don't have hypercalcemia, renal problem, or anemia. Pathogenesis and clinical manifestation of the Angus: 25% progress to malignant disease, remain asymptomatic until fairly advanced. That's the worst, because when you diagnose the patient, it's extremely advanced. Diagnosis of routine examination during asymptomatic phase: protein in the urine, high serum calcium levels. Listen, this PowerPoint is like basically out of order because this is for multiple myeloma, not for Angus. Okay. First symptom, usually bone pain. Bone pain, why? Because you have hypercalcemia. That means that you are removing the calcium from the bones, and then that produce pain in the bone. Okay. Also can produce constipation, muscle weakness, because hypercalcemia produce constipation and muscle weakness. Bone marrow depletions, indicator of anemia, recurrent infection, bleeding tendency. Prognosis of clinical manifestation: renal insufficiency, 50% with multiple myeloma. And what is extremely important right here, bone involvement consists fissures. X-ray show honeycombs appearance in ribs, spine, skull, and pelvis. That's pathologic fracture, because remember that if you remove the calcium, the bones get like weak, and then you are at risk to fracture. The treatment is anti-neoplastic agent, induced maintains remissions, best chemotherapy regimens not yet determined, high-dose chemotherapy followed by allogenic bone marrow transplants. But bone marrow transplants is for example, young people that are not extremely old, and they have to follow some characteristics. Prognosis and treatment: autologous stem cell transplant, optimal initial therapy, pharmacological management for renal dysfunctions and chronic bone pain, common problems, narcotic and localized application of radiation to bone lesion. Now we have the Hodgkin lymphoma. Hodgkin lymphoma presents about 30% of malignant lymphocyte. The onset age is 20 to 40. Okay, higher incidence in male, and that's some statistic. Let me give you the most important. This is extremely important in Hodgkin lymphoma. Stem cell. Okay, stem cell. Okay, that's the main characteristic of Hodgkin lymphoma. Okay. Let me see, Epstein-Barr virus, frequent found in genome of transformer Ritz-Tember cells. Epstein-Barr virus is related with Ritz-Tember cells, also related with Burkitt lymphoma. Pathogenesis of clinical manifestation type, we have rare lymphocytic predominance type and classic type. Those are the different type of Hodgkin lymphoma. Are extremely weird because it's according to the presence of lymphocyte, basically. Prognosis and clinical manifestation. Early stage often asymptomatic. Painless lymphadenopathy, that's the main characteristic. Possible with fever, night sweat, little weight loss, that's the B symptoms. Lymph node enlargement above diaphragm, cervical node, most common site. Node below diaphragm, less common. Primary site. More common is over the diaphragm, especially in the neck. Okay. We have Ann Arbor staging systems, that's special for non-Hodgkin lymphoma, usually present and absent of certain clinical symptoms, 4 stages, 4 modifying characteristics. Prognosis and treatment. A, absence of clinical symptoms. B, symptoms present at the time of staging. C, S, based of history. And P, S, determined by invasive procedures result. Prognosis is staging dictate treatment modality. Basically, is for not only for this one, for all the type of tumor. You have the stages, and according to the stage is the prognosis of the patient. Okay, and we have the question number 3: which finding is associated with Hodgkin disease? Okay, exactly, because that's the most important for Hodgkin disease. Ritz-Tember cell. Okay, Ritz-Tember cell. And when you see Ritz-Tember cell in a blood smear, is you never forget, because it's basically like twice like this. It's like 2 cells really close with the nucleus right here. Basically, that's the Ritz-Tember cell. Okay. Now we have B cell, T cell, and natural killing. We have non-Hodgkin. Okay, we already covered Hodgkin. Now we have non-Hodgkin. Non-Hodgkin, of course, we don't have Ritz-Tember cell. Majority arrive from lymph node, but can originate in any lymph tissue. 95% in older adults, but also we have non-Hodgkin that are in children, especially Burkitt lymphoma. That's a type of non-Hodgkin. Prognosis vary according to the type, group of indolent or aggressive. Indolent, that is less severe, longer survival. Aggressive is disseminated at present for prognosis. We have similar to other malignants, that's the pathogenesis, tumor cell derived from single mutant precursor cell, of course. Virus, of also can be involved, like Epstein-Barr virus with the Burkitt lymphoma. Most present with advanced stage, that's the staging in 3 and 4. Painless lymphadenopathy is the same. All those diseases have the same painless lymphadenopathy, fever, night sweat. Okay. The main difference is when you do the cytology, when you get the blood smear and you see under the microscope that you identify the cells. Okay. The complications include two serious oncology emergencies: superior vena cava obstruction and spinal cord compression. Okay, if the lymph node in the neck are extremely swelling, they can make an obstruction of the superior vena cava. If you make an obstruction of the superior vena cava, there is no drainage of the blood from the head and the upper limbs. Then you have swelling of the neck, head, and the upper limbs, and that's the superior vena cava syndrome. Is a surgical emergency. You have to remove that lymph node to release the obstruction. Okay. Prognosis therapy effectiveness vary. Stage 1 and 2 fireable, of course, is less severe. 3 and 4, the outcome is not really good. Okay. Common therapy, we have radiation, we have chemotherapy, and bone marrow transplant, of course. Any question from this chapter? Again, always remember, I know that is a lot of information, but you have to focus in the key points, okay? Because question go straight to those key points. If you know those key points, also on the review, I'm going to, emphasize in those key points that you have the best information. Okay, let's stop right here. Then let's go to the last chapter. We really, I know that we are tired, but we have to finish. That then you get relaxed and also remember you have to study. Okay, let's go back. Now we have chapter 13, that is alteration in oxygen transport. Okay. Now we are gonna be see the composition of the blood. Composition of the blood is the total blood volume. In men is 75% millimeters per kilograms. In women is a little bit less, and is always around 7 to 8% of the body weight. That includes like 5 to 6 liters of blood. Okay, blood cells make up to 45% of blood volumes, and plasma is 55. Okay. Organic and inorganic composition. Plasma protein forming the liver contribute to colloid osmotic pressure. Remember that colloid osmotic pressure is the one that keep everything inside the blood vessel. Okay. The general type of plasma cell, we have the albumin, the globulin, and the fibrinogens. Okay. Regular proteins, hormones, and enzymes also in plasma. Organic constitution, produce of tissue metabolism, nutrient organic material. In organic constitution, we have electrolytes and iron. In the cellular components, that is the form elements, we have the erythrocyte, leukocytes, and platelets. Another name for platelets is thrombocyte. Erythrocytes, thus the most numerous, is 4 to 6 millions, and one of the main functions is transport of oxygen to tissue and remove carbon dioxide from tissue. We have the buffer blood pH, that's the erythrocyte, because we have the carbonic anhydrase, that's an enzyme that produce bicarbonate. Main functions constitute hemoglobins, small biconcave discs, reversible deformability. Leukocyte, we have the white blood cells, the normal value from 5,000 to 10,000 is they made the immune antibody. Okay, and platelet, the normal value is from 150,000 to 400,000, and the main function is coagulation. Okay. Let me go back, let me see, because 1/3 of the body platelet are in reserve in the spleen. That's extremely important. That's why the spleen is so important for platelets. Limit to structure and function of the red blood cell, limit to marrow the body skeleton after birth, retain until maturity. So the bone marrow is the formation of the red blood cell when you are an adult, okay? Because in the embryonic period, the red blood cells first are formed by the liver, then by the spleen, and when you are in the childhood, then everything goes to the bone marrow. Hematopoiesis is development process of RBC, red blood cells. Okay? Hematopoiesis continue throughout life and can be accelerated by increase in differentiation of daughter cell, increase in number of stem cells, conversions of yellow bone marrow to red marrow. Hematopoiesis, we have two stages: mitotic division, proliferation, and maturation, that is the differentiation. In that process of differentiations, the red blood cells, they release the nucleus, because red blood cells are one of the few cells that we have in our body that doesn't have any nucleus. Okay. Hemoglobin synthesis, immature RBC, factory of hemoglobin, hemoglobin oxygen carrying proteins, and hemoglobin carrying oxygens is oxyhemoglobin. Okay, that's when the hemoglobin is carrying the oxygen. Hemoglobin synthesis, two pair of polypeptide chain. The hemoglobin contains four polypeptide chains, 2 alpha and 2 beta when you are an adult, okay? Because in the embryonic period we have difference, in childhood then we have another, but when we are an adult person we have 2 alpha and 2 beta, okay? Nutrition required for erythrocyte. We need the folate and B12. Folate and B12 are essential, okay, to make the red blood cells, okay? That's why you have deficiency of folate or deficiency of B12, produce anemia, okay? Because you can make the DNA. Energy and maintenance of erythrocyte, that's the lifespan of the erythrocyte is 120 days. An anaerobic enzyme Maillard-Hoff pathway provide ATP for regulation of electrolyte via cation energy and maintenance of erythrocyte, aerobic hexose, monophosphate ions protect cell from permanent oxidant injury, metahemoglobin reductase pathway protects hemoglobin from oxidations, so on. And now we have red blood cell production, erythrons. Erythron is blood as a single body system composed of blood cell and bone marrow precursors. Erythropoiesis regulated by the concentration of hemoglobin in blood. Increase to decrease hemoglobin kidney secretion erythropoietins. Because for the process of erythropoiesis, we need erythropoietin. Okay? And erythropoietin is a hormone produced by the kidney. Red cell distributions, when you see a CBC, we have this metahemoglobin is removed by mononuclear phagocytic system. Globin is broken down into amino acid and ions is recycled. Porphyrins is reduced to bilirubins. That's why sometimes when you have the destruction of the red blood cell, you can produce jaundice, okay? Because when you destroy the red blood cell, you produce bilirubin, okay? And we have question number 1. Which of the following situation will result in the release of erythropoietin? Remember that erythropoietin is used to make red blood cell. Okay? Vacation trip to tropical area, a beach, a growth spurt in adolescent, a patient with lung disease and chronic hypoxemia, a patient with an oxygen saturation of 98, and the answer is this one, hypoxemia. Doesn't matter if the patient have lung problem, any problem that produces hypoxemia, you start secreting erythropoietin, okay? Because hypoxemia means that the oxygen is low, okay? Low oxygen. I mean, hypoxia is low oxygen. Hypoxemia is low oxygen in the blood. Now we have gas transport and acid-base balance, oxygen combined with heme portions to form oxyhemoglobin. Okay, I'm gonna explain. I'm not gonna read the PowerPoint. I'm gonna explain it. Okay, listen. The transport of oxygen in the hemoglobin. Remember, in the hemoglobin we have the heme group. Heme group contain the protoporphyrins and the iron. Iron is the one that attach the oxygen. Okay, when the hemoglobin, the blood, is in the lungs, they release CO2 and they get the oxygen, then go to the tissue, and in the tissue they release the oxygen, and they get the CO2 and then go with the CO2 back to the lungs, and then you release the O2 in the breathing. Oxygen transport, each hemoglobin molecule combines 4 atoms of oxygen, and that's how you measure the oxygen saturation rate. Oxygen transport, partial pressure of oxygen reflects the pressure of tension that oxygen exerts when it dissolves in blood, and so on. Out of all this, what you have to know is that in pulmonary capillary, when PO2 is high, what you have to know is that the hemoglobin, when it's in the lungs, they increase the affinity for O2. So ions, that is this is iron. And they have 2 stages in our body, +2 or +3. Okay. When the iron is in the lungs, they become like this, +2, and they attach the oxygen. When the iron get to the tissue, they become this, +3. They release oxygen and they attach to the CO2, carbon dioxide. Okay? And right here we have, let's keep going. Hello. I have some technical issue, but we are right here. Okay, let's keep going with the blood. Okay, can everybody hear me? Yes, okay, let's keep going. Okay. Now we have oxygen transport in the lung where PO2 is high. This is the same that I already explained. And then we have oxygen affinity of hemoglobin for oxygen is affected by temperature, acid-base status, 2,3-DPG levels, and carbon dioxide. Okay, that's how you affect the uh, oxygen transport. Okay, and also high altitude. That's another one. Oxygen transport affinity decrease at the tissue level because of increased level of acid, 2,3-BPG, and carbon dioxide. Okay, then shift to the right of the hemoxyglobulin. This association curve enhances oxygen uploading to tissue. Okay, oxygen transport achieved to the left occur in the lungs. Blood is more alkaline and carbon dioxide levels are lower. And when you are in the lungs, you increase affinity for oxygen. And we have question number 2. If a patient have a fever and is acidotic, the oxygen hemoglobin dissociation curve will shift to D, causing the affinity of oxygen for hemoglobin 2. So remember, right here we have fever, that is high temperature, and acidity. Okay. Now the answer is B. Okay. The shift go to the right, and the oxygen for hemoglobin decrease. Okay. Now we have carbon dioxide transport in the blood by dissolved gas by carbonate ions. That's the biggest transport by carbonate. Partial pressure of carbon dioxide reflects the pressure of tension it exerts when dissolved in blood, expressed as PCO2. Remember that also we have PO2. Partial pressure of the carbon dioxide and partial pressure of the oxygen. In pulmonary capillaries, CO2 easily dissociates from hemoglobin and then diffuses across the alveolar membrane into the alveolar sac. In body tissue, CO2 inside the cell diffuses into the blood and attaches to the hemoglobin as oxygen is released to the tissue. RBC contain an enzyme carbonic anhydrase. Enzyme carbonic anhydrase is converts CO2 and water to bicarbonate and hydrogen ion. Okay. Now we have decreased oxygen reaching to the tissue result in secretion of erythropoietin and increase in the production of RBC. Factors that decrease hemoglobin mass, anemia, of course, decreased arterial saturation, hypoxia, lead to increased release of erythropoietin, of course, because it's a mechanism of reaction of your body. Anemia is the deficit of the red cells of oxygen carrying capacity lead to hypoxia. Opposite of anemia is polycythemia, the polycythemia vera. Polycythemia vera, we have two, primary and secondary. Relative anemia, normal total red cell mass with disturbance in regulation of plasma volume. Absolute anemia, actual decrease in number of red cells. Okay. Relative anemia, you could see relative anemia, for example, in pregnant woman. Pregnant woman, in reality, they don't have anemia. The problem that they have an overload of fluid. Okay, they have a lot of volume, and because they have a lot of volumes, they make that you have anemia. Okay, that's not relative anemia, that's dilution anemia. Okay, reduction in oxygen carrying capacity, tissue hypoxia, compensatory mechanism to restore tissue oxygens, increase heart rate, cardiac output. Of course, you are lacking of oxygen, your heart start pumping really fast. Okay, increase to 3 DPG and increase in erythropoietin activity to make more blood. Mild anemia, usually no clinical symptoms. Elderly with cardiovascular pulmonary disease may have some symptoms, mild to moderate anemia. Then the patient start getting like fatigue and all the symptoms. Moderate to severe anemia, orthostatic and generalized hypotension, vasoconstriction, pallor. Orthostatic is when the patient is in a sitting position that they stand up, the blood pressure go down. Okay, that's orthostatic hypotension. That could be because of problem in the baroreceptor, or most of the time in elderly patient is due to dehydration. Tachycardia, dyspnea, tachycardia, transient murmur, angina pectoris, heart failure, intermittent claudication, night cramps in muscle, headache, tinnitus. Tinnitus is like sound in your ear, like beep, that sounds in the ears, that's tinnitus. Aplastic anemia is one type of anemia. It's an stem cell disorder characterized by reduction of hematopoietic tissue. Fatty marrow replacement, the bone marrow is replaced by fat and produce pancytopenia. That's a characteristic of aplastic anemia. Pancytopenia means that the red blood cell, white blood cell, and platelet, everything is low. Aplastic anemia, insidious onset symptoms. Late symptoms include weakness, fatigue, lethargy, pallor, dyspnea, palpitation, thrombocytopenia, prone to bleeding, and neutropenia, prone to infections. Treatment: identify and avoid further toxic exposure, because there are some type of medication that produce aplastic anemia. Type human leukocyte antigens. Maintain minimal essential level of hemoglobin and platelet, and prevent and manage infection. Treatments determine efficacy of bone marrow transplantation. Administer immunosuppressive therapy, and the prognosis is fatal unless bone marrow transplant is successful. Anemia of chronic renal failure, failure of the renal endocrine function, impair erythropoietin. If you don't have erythropoietin, you don't produce red blood cell, and then you develop anemia. Hemoglobin is always related with hematocrit. Okay? They have like a proportion. For every one of hemoglobin, the proportion is 1 to 3. Okay? From 1 hemoglobin, you have 3 hematocrit. So a patient, person with hemoglobin of 10, the hematocrit is 30. That's the proportion, okay? You have to know that, because I don't know, but sometimes in the CBC they only report the hematocrit. That's some questions, In real life, they always put everything. Anemia of chronic renal failure, treatment, dialysis. Of course, you have chronic renal failure, you have to give dialysis, and you have to give erythropoietin. the patient. Okay. Anemia related to vitamin B12 and folate deficiency. Okay, anemias. Always, when you have a patient, you have to see the hemoglobin. With the hemoglobin, you know if the patient have anemia. Then the next step is that you have to see the MCV, mean corpuscular volume. Mean corpuscular volume is always 80. Those are the normal value to 100. Okay. So then anemia is classified in 3 groups. Okay. One group is with normal NCV, 80 to 100. Another group is when the NCV is lower than 80. That is a microcytic anemia. Okay. Then the other group is when the NCV is higher than 100 and is the macrocytic anemia. And these two type of anemia right here, B12 and folate, is a macrocytic anemia, NCV higher than 100. Okay. And you see folate deficiency. From that deficiency, alcoholism is really common. Folate deficiency in alcoholism, cirrhosis, pregnancy, or infancy. And we keep going. One of the main differences between B12 deficiency and folate deficiency is neurological sign and symptom. Okay, neurological sign and symptom is only present in B12. It's the only one that have neurological sign and symptom. And it's called this megaloblastic anemia. The treatment recognizes that megaloblastic anemia is present, ascertain if vitamin B12 and folate or combination deficiency. The most common one is folate. That's why basically you start giving folate. If the patient don't improve, then you give B12. There are some tests that you do to differentiate one to another one. And the main test is methylmalonic acid. Okay? If you have presence of methylmalonic acid, that's B12 deficiency. And we have right here treatment, B12. Also B12, you have to be very careful in vegan. People that just eat vegetables, strict vegans, because when you eat B12 is only from animals. So people that are extremely strict vegans, they don't eat any product from animals, they could develop B12. The good thing is that B12 stay in your body for a lot of years. So you have to be vegan for a lot of years, for I think more than 6 or 7 years to develop the anemia. Okay. Iron deficiency anemia. Okay, then you remember that we have microcytic that is less than 80. This is a type of microcytic. Okay, in the microcytic we have the, let's say this, T E S. Okay, this is an I. Okay, let me put the PV right here. Yes. Okay, in the microcytic anemia we have thalassemia, iron deficiency anemia, anemia of chronic disease, and sideroblastic anemia. Those are the type of anemia in this group. And we have the iron deficiency anemia. Is the most common nutritional deficiency, insufficiency irons, hypochromic, microcytic RBC, low NCV, NCH, and NCSH. You have to know this because this is equation in your test. Okay, you have to know this. Serum ferritin level is decreased, serum iron level is decreased, and the only one that is increased is total iron binding capacity. The only one that is increased, okay? You have anemia of chronic disease, then the ferritin is gonna be elevated. Okay? Iron deficiency anemia, PICA is like one disease that can produce iron deficiency anemia. It's not always you're gonna develop. They can produce iron deficiency anemia, and PICA is people that eat something that is not food, okay? Especially dirt, clay, ice, okay, and that can produce iron deficiency anemia. Pyelonechias is spoon-shaped nails. Those are the nails that are like this and bend in the front, and it's due to anemia, but most of the time it's due to hypoxemia, okay? Chronic condition that produce hypoxemia, the patient develop this type of nail, okay? Blue sclera also could be present, but you have to be very careful. Blue sclera is extremely common in osteogenesis imperfecta. Iron deficiency anemia, treatments, oral administration of ferrous sulfate. You have to be careful when you give iron to the patient, okay? Because iron is toxic to our body, okay? So you have to be very careful with giving iron to the patient. And we have question number 3. Which anemia will cause the RBC to be hypochromic and microcytic and can cause PICA? Okay, so exactly. Listen, iron deficiency anemia is microcytic. Pernicious anemia is macrocytic. Okay, M and A. Macrocytic anemia. Acute blood loss, that's normocytic. Polycythemia vera means a lot of RBC. It's not a type of anemia. Now we have thalassemia. Thalassemia is a problem in the hemoglobin, okay? It's a hemoglobinopathy, something like that. It's a problem in the structure of the red blood cell, of the hemoglobin, okay? Remember that we have alpha and beta chains in the hemoglobin. Then you have deficiency of the alpha, then you have alpha thalassemia, deficiency in the beta, then you have beta thalassemia. Those diseases are extremely common. Alpha in the Asian populations, Mediterranean. Beta is more common in the Mediterranean and in, I think, Africa. Yes. Thalassemia is hypochromic, microcytic anemia. NCV, NCH, and NCHC are low. Erythroblastosis, hyperplasia, bone marrow is I think it's the worst condition. There is a disease that is called erythroblastosis fetalis that is due to severe thalassemia. Treatments most of the time is blood transfusions, splenectomy, chelation therapy. Chelation therapy is due to the blood transfusion, okay? Because when you transfuse blood to the patient, you are giving a lot of iron to the patient, and then the patient maybe develop hemochromatosis. Hemosiderosis is a condition that you accumulate too much iron in your body, and then you have to give a chelating agent, remove the excessive of iron. Bone marrow transplant and genetic counseling, always genetic counseling to those patients. Now we have sickle cell anemia. Sickle cell anemia, also again, we have under 80, from 80 to 100. Sickle cell anemia is a normocytic anemia. Okay? The NCV is going to be from 80 to 100. It's normal. It's a genetic condition. It's common in the pediatric populations, and is a mutations in the right now I don't remember in what chromosome. It's a mutation, it's a point mutation in the position, in the sixth position, okay? And it's a chain of 2 amino acids, okay? Let's keep going. Also, that disease is common in Africa, okay? That's endemic in Africa. It's endemic due to an endemic disease in Africa that is malaria. Okay, malaria is endemic in Africa, and people with sickle cell anemia, they have protection for malaria. Okay, those people are resistant to malaria. We have crisis. We have two types of crisis in those patients. One is the I don't remember. It has to be around here. Okay? Immune choice is a stem cell transplant, is the curative, but we have a couple of medication that we give to those patients. Okay. Now we have another disease that is hereditary spherocytosis. Spherocytosis, when you see a blood smear that is under the microscope, that you see the red blood cell, you're gonna see that the blood is like an sphere. Okay? They lost the pallor in the middle because the red blood cell is like a donut, okay, and this is like this, okay. All this outside is like intense red, and this is like pallor, okay, in the middle. The erythrocytes is like a ball like this with homogeneous color. Okay, it's an autosomal dominant trait. RBC are fragile to microspherocytes. Actually, there is one test that is osmotic fragility. Is the test. You put that cell in a solution, the cell explode, and then if the cell explode, that means that is positive. You have spherocytosis. Treatment of splenomegaly, always does splenomegaly, okay? One of the main characteristics of spherocytosis is that the NCHC mean corpuscular hemoglobin concentration is high. Is the only anemia that increase the NCHC. Now we have G6PD, glucose 6-phosphate dehydrogenase deficiency. That's called G6PD. The G6PD deficiency is a problem in the RBC. That's an enzyme that we need for protection of the RBC. Those patients doesn't have that enzyme, and then they develop disease. Most of the time, you see those patients when they have like when they are exposure to a trigger. One of the triggers is this faba bean. Okay, those patients can eat faba bean. Okay, and there are some type of medication that also produce crisis in those patients. Okay? Like hydroxychloroquine produce crisis in those patients. Hemolytic disease of the newborn. Hemolytic disease of the newborn. We have ABO incompatibility and RH incompatibility. ABO is more mild. Okay? Is the most common one and is more mild. RH incompatibility is more severe and can produce erythroblastosis fetalis that the patient is going to die. Treatment standard dose of anti-RH, that's the Rogan you give to the mother before and after delivery. of the first pregnancy, okay? Because the patient can develop the disease in the second pregnancy. Okay? Because in the first pregnancy, you develop the antibody, okay? Antibody-mediated drug reactions, okay? Exposure to a drug causes destruction and lysis of the sensitized person on RBC. Mechanisms include active mechanisms, neoantigen formation, membrane modification, and antibody induction. May have schistocyte. Schistocyte is also, when you see a blood smear, the blood is like this, it's like that. Schistocyte because you're like basically smiling, and then that's why it's called schistocyte. Antibody-mediated drug reactions, streaming, recognize and discontinue the offending agent always, and sometimes steroid is given because steroid decrease the inflammation reaction. Acute blood loss, of course, if you have any trauma, penetrating trauma, or any accidents that you have in blood internal hemorrhage that can produce anemia. In those cases, you have to give IV fluid to the patient and send it to the OR. Treatment, blood volume replacement, IV fluid, and send it to the OR, always. 2-bead bore IV, okay, 2 huge IV, completely open, and sometimes, most of the time, you have to give red blood cell to those patients, okay? Other intrinsic anomaly, mechanical heart valve, also can produce mechanical destruction of the red blood cell and can produce anemia, okay? Extrinsic anomaly, venom from insect of a snake. Of course, there are some toxins that attack the red blood cell. Hyperesplenism and splenomegaly can result in anemia, leukopenia, or thrombocytopenia. So problem in the spleen can produce anemia. That's why patients with sickle cell, they have autosplenectomy, okay, because they destroy their own spleen due to the type of anemia that they have, okay. Transfusion therapy, medical indication include restoration, maintain of oxygen carrying capacity, blood volume, metastasis, hemostasis, and leukocyte function. To indicate transfusion to the patient, first of all, most of the time, because transfusing the patient is a little bit complicated, but you have to, the hemoglobin has to be under 7, okay? Until 7, most of the time you don't give any transfusion. If the patient is under 7, then you give the transfusion. Or if they change the hemoglobin is really fast. So that means that hemoglobin is dropping really fast, then you also give the transfusion. But most of the time, the number that you have to know is this one, 7. And then the hematocrit, 21. Serious complication, we have transfusion-related acute lung injury and transfusion-related circulating overload. Polycythemia, remember that polycythemia is a lot of red blood cell, and in polycythemia we have 2 types of polycythemia, primary and secondary. Primary polycythemia vera is due to neoplasia. Okay, it's a neoplasia, and the erythropoietin is normal low. Secondary polycythemia vera, the erythropoietin is always increased, okay, because it's due to another condition, okay. Treatments reducing increased blood volumes. You have to give phlebotomy. Phlebotomy means to draw blood. Okay. The radioactive phosphorus and chemotherapeutic agents. Secondary polycythemia vera caused by chronic hypoxemia and conditions that decrease the RBC, okay, the red blood cell, okay. And also again, treatment could be phlebotomy. Relative polycythemia caused by dehydration with a spurious increase in RBC production to group disturbed fluid balance and stress polycythemia, elevated hematocrit, hemoglobin, and red blood cell count. Treatment recognize the problems and then treat the underlying condition. Any question from this chapter? Okay, I know that this was a really long